This is Mrs. Dagan podcasting part of the Fractures Lecture for Nursing 151. A fracture is a break in the bone secondary to trauma or a pathological condition. Trauma is most common. Causes of fractures. One cause can be accident or injury, either by direct blows, crushing forces, sudden twisting motions, or extreme muscle contractions. Second cause would be osteoporosis. Third cause, aging. In general, younger patients have more resilient bones that bend and flex. Bones become less dense with advancing age. Also, diseases that erode the bone structure, such as cancer, can cause fractures, and bone fatigue, in which healthy bones are subjected to prolonged excess stress. We need to remember that adjacent structures are also affected with fractures. So there can be soft tissue edema, hemorrhage into muscles and joints, potential joint dislocation, ruptured tendons, severed nerves, and damaged blood vessels. Moving on to the next slide. Fracture classifications. Closed fractures, or simple fracture, does not break through the skin surface. Open fracture disrupts the skin integrity, causing an open wound and tissue injury, and with that comes the risk of infection. Complete fracture goes through the entire bone, dividing it into two distinct parts. Incomplete fracture goes through part of the bone. An example of this would be the green stick fracture. And there's a picture there for you to see the difference between the simple or compound fracture. You can take a look at the specific types of fractures in your book, page 1117. Two kinds I wanted to specifically point out is the spiral fracture. It's in the picture, the bottom second from the left. A fracture that twists around the shaft of the bone. When this happens with children, we need to consider possible child abuse. Also, green stick fracture is a fracture that occurs on one side but does not extend completely through the bone, and this is most often seen in children. Next slide, moving on to signs and symptoms. Diagnosis of a fracture is made by symptoms, physical signs, and an x-ray. So there's pain, immediate, continuous, increases in severity until the bone is immobilized. Muscle spasms, due to the pulling forces when not aligned, and usually begins within 20 minutes. Loss of function. The normal function of the muscles depend on the integrity of the bones. Deformity. Displacement causes visible or palpable deformity. You could see the visible bone with an open fracture. You also could see internal rotation of the extremity. Shortening because of the contraction of the muscle in the long bones. Crepitus. Upon palpation, a grating sensation, which is bone rubbing against each other. And swelling. Localized swelling and discoloration or ecchymosis occur as a result of trauma and bleeding into the tissues. Next slide. So how is fracture diagnosed? An x-ray can determine the type of fracture and the location. In addition, x-rays can tell some things about bone density, texture, erosion, changes in bone relationships, fluid, and spur formation. And serial x-rays or several x-rays are used to determine if a bone is healing. Bone scan might also be ordered. Bone scan is useful to help detect bone tumors, look at fractures, determine osteomyelitis, bone infections, or aseptic necrosis. With a bone scan, an isotope is injected into the IV, and then the scan is performed 2 to 3 hours later, and the scan looks for the uptake of the isotope. It is important to assess your patient for a contrast dye allergy. asking them if they have any history of iodine allergy or allergic to shellfish. The bone scan is helpful to look at hairline fractures. CAT scan might be often used with fractures of the hip and pelvis, and it takes cross-sectional images. It shows in detail a specific plane of the involved bone and can reveal soft tissue, injuries to ligaments or tendons. It's used to identify the location and the extent of the fracture in areas difficult to evaluate. CAT scan may be performed with or without iodine contrast and lasts for about 1 hour. MRI uses magnetic fields, radio waves, and computers to demonstrate abnormalities of soft tissue. So it's looking at muscles, tendons, cartilage, nerves, and fat. So MRI is usually not used to diagnose the fracture, but look at the surrounding tissue. Precautions for MRI include, because an electromagnet is used, no metal, so patients with metal implants, clips, and pacemakers are not candidates for MRI. It's important to assess the patient and remove any transdermal patches because they can cause burns during the MRI, and notify the provider prior to removal of the patch. Need to remove jewelry, hair clips, hearing aids from the patient, and no credit card should be in the MRI room because the magnetic strip can be erased. IV contrast may be utilized or may not. MRI generally takes 1 to 2 hours, and make sure your patients know they will hear a loud knocking sound. Usually they're given some sort of music to listen to, and they're given a call bell to ring if they need anything. But it's important to understand whether your patients are claustrophobic or not. The open MRI is good for claustrophobic patients, and there's reduced noise with it and increased patient comfort. However, the disadvantages of the MRI, open MRI, is that there's reduced quality of the images, and this is because there's lower intensity magnetic fields. So what are your immediate priorities, moving on to the next slide, for a fracture? You need to provide emergency care at the time of injury, and I can think of this if you're working in a setting where suddenly someone fractures something, like if, for instance, if you're working in a nursing home and there's a fall and a fracture. You need to maintain the airway, breathing, and circulation. Monitor vital signs and neurological status, because remember that injury to organs may occur with fracture fragments. It's important to immobilize the patient, immobilize before the patient is moved. Support the limb distal and proximal to the fracture site. Prevent rotation and angular motion. Splinting, taping, and bandaging are used. Do not do too tightly, and it's important to immobilization applied to joints above and below the fracture. It is important to assess the neurological status distal to the injury before and after splinting. Then you should be assessing neurological status, especially distal to the injury, at least every hour for the first 24 hours. 5 P's, the warning of neurovascular impairment. Pain should be assessing level, location, and frequency. Immobilization, ice, and elevation, along with pain medicine, should help control the pain. Poikilothermia is cold limb. Extremities should be warm, not cool to the touch. Pallor is paleness. Again, we're looking for it to be pink, not pale. Paresthesia, which is numbness, pins and needles, tingling. Remember, paresthesia is an early sign of neurovascular compromise. And pulselessness. This includes weak pulses, delayed capillary refill. Normal capillary refill should be within 2 to 3 seconds. Moving on to the next slide, you need to monitor vital signs and assess for bleeding. If there's any overt bleeding, you need to hold pressure. Hypovolemic shock results from blood loss and loss of blood volume into the interstitial space. Signs and symptoms of shock include increased pulse, weak or thready pulse, decreased blood pressure, rapid respiratory rate, cool, clammy skin, delayed capillary refill, anxiety, and sometimes patients feel thirst. How is shock treated? Well, stabilization of the fracture to prevent further hemorrhage is needed, restoring blood loss, such as fluids, and protecting the patient from additional complications and injury. It's good to remember that it depends on what bone is affected, how much the patient is at risk for hypovolemic shock. And here's a quote from your book. Because the bone is very vascular, large amounts of blood may be lost as a result of trauma, especially fractures to the femur, which is the thigh bone, and pelvis. Pelvis results in more blood loss than the femur, but both result in lots of blood loss. Need to elevate the limb above the heart and apply ice. Be on guard for infection prevention. If an open fracture, cover the wound with a sterile dressing. Open fractures need prompt, thorough wound irrigation and debridement, which works to remove foreign bodies, debris, and bacteria. This is done in the operating room. Open fractures, in addition to sterile wound dressings, need tetanus prophylaxis and broad-spectrum antibiotics. It is also important to remove clothing or jewelry on the affected extremity or near the injury to prepare for the treatment that's needed and also with the swelling. And pain control. Assess for pain frequently and follow pain management protocols. Management of the fracture, reduction. It's important to set or align the bones as soon as possible before edema and hemorrhage restricts the reduction process. So closed reduction, the extremity is held in the desired position while the provider applies a cast or splint. This may be done in the operating room to visualize during reduction and take x-rays afterwards. So closed reduction is when a pulling force is applied manually to realign the displaced fractured bone fragments. Then immobilization follows to allow the bone to heal. Open reduction, internal devices are used such as metallic pins, wires, screws, plates, nails, or rods to hold the bone fragments in position until healing occurs. For open fractures, wound irrigation and debridement is necessary, as I mentioned. An example of an open reduction is called an ORIF, which is open reduction with internal fixation. So moving on to the next slide. So external, well, let me say first, immobilization secures the injured extremity in order to prevent additional injury, promote the healing and circulation, reduce pain, and correct the deformity. So immobilization can be externally accomplished. One option is traction, which I'm going to talk more about in class when we discuss hip fractures. Also, splints, immobilizers, and braces are used, and this can be applied often until the swelling is reduced and then a cast is applied. Casting and external fixation, which I have a picture of that on an upcoming slide. Also then, an open reduction, internal fixation, is when a surgical incision is made and the bone is manually aligned and then kept in place with plates, screws, pins, and or rods. After the bone heals, the hardware may or may not be removed depending on the location and the type of hardware. Another option for immobilization is a hemiarthroplasty, which is a replacement of the femoral head with a prosthesis. And this is similar to a total hip replacement, but it only replaces the ball portion of the hip joint, not the socket, as is replaced in the total hip replacement. Okay, so immobilizers and splints. You need to teach your patient about the splint or immobilizer. Need to know based on what the provider specifies. Does it stay on all the time, and can it get wet? Also instruct the patient to observe for skin breakdown at pressure points and report any problems to the provider. Patients should also be moving unaffected fingers, for example with a hand splint, and watching circulation. Moving on to CAS. A CAS is a rigid external immobilizing device. It allows mobilization of the patient while restricting movement of a body part. Some patients may not need a CAS, they might just be able to have an immobilizer. CAS can be fiberglass or plaster. Fiberglass is a water-activated polyurethane material that's light and strong and tends to be more water resistant and durable. There is usually a cotton roll placed first to protect the skin before casting. Plaster would be viewed as a traditional cast. That's rolls of bandages that are wet in cool water and applied to the body. Inform the patient that they will feel warmth during the application and approximately 15 minutes after, and it takes a full 24 hours, maybe more, up to 72 hours to dry. Nursing care for a patient with a cast. Exercising the joint above and below the cast, such as finger range of motion in the case of an arm cast, is helpful to maintain flexibility and muscle strength, promote circulation. If a patient has an arm cast, you need to know, should the arm be supported with a sling or left hanging? Slings, if they wear a sling, make sure that there's no neck pressure, and patient should continue to move their fingers. This will all be specified by the provider. Are the patients allowed to bear weight, or are they non-weight bearing or partial weight bearing? If they are non-weight bearing, do they need a crutches or a walker? If they're partial weight bearing, are crutches, a walker, or a cane needed? Or full weight bearing, perhaps they still need a cane. It is important to teach your patients how to use the assistive devices. Additional patient teaching. If plaster is used, you need to allow the cast to dry completely. Then the patient may or may not be allowed to get it wet. Ice may be ordered for the first 1 to 2 days. It's important to elevate the extremity at the level of the heart when seated to promote venous return and control swelling. Do not itch underneath the cast or put anything down the cast. A cool hairdryer may help relieve itching. Report excessive itching to provider. Important to teach self-care, how to take a shower, or do they need to keep the cast dry, or are they allowed to get it wet? Report persistent pain, swelling that does not respond to elevation at the level of the heart or above, changes in sensation, decreased ability to move exposed fingers or toes, changes in capillary refill, or changes in the color of the extremity, any odors or drainage. Patient should mark them with a marker on the cast. Warm spots, and if the cast breaks or gets wet. When they get the cast off, prepare the patient for a loud noise and vibration, which is cast cutter, especially children. After the cast is off, gently wash and dry the area and apply lotion. Teach the patient to avoid rubbing or scratching. They will often be tempted because it's dry skin underneath there. Work with physical therapists and provider for increasing activity of the affected areas. Assessing for complications with the cast. 3 complications I'm going to talk about. One's compartment syndrome, which I'm going to talk about more in detail coming up. But if compartment syndrome is suspected, the surgeon will do what's called bivalve the cast. It's cut it in half lengthwise. And the nurse's responsibility during this is to help maintain limb alignment and help with elevation and continue to monitor circulation, sensation, etc. Pressure ulcers is also a concern. Breakdowns in the skin caused by prolonged pressure on a body part. And the high-risk sites are demonstrated in that picture. Areas on the heel, the head of the fibula, tibial tuberosity, anterior surface of the knee, medial and lateral epicondyle of the humerus on the styloid. Signs and symptoms. Patients should report pain and tightness in the area. Could be warmth, odor, drainage on the cast. Sometimes a window may be cut to see the affected area by the provider and assess for edema through the window cut in the cast. Removable braces might be a better option for those patients with neurological impairment or impaired sensation. And then disuse syndrome is when the muscle is left inactive and then therefore results in losing muscle strength and size. Nurses need to encourage patients to do isometric exercises every hour while awake, such as make a fist. Physical therapy can develop an exercise plan for a patient with a cast. Next slide. This is a picture of an external fixator. This is used to maintain position of unstable fractures. So the fracture is reduced, aligned, and immobilized by pins and screws inserted into the bone. The nurse should never adjust any of the clamps on the external fixator frame. This is the physician's responsibility. So several advantages of this include there's less blood loss to stabilize the fracture. The fixator often allows patients earlier mobility, so the complications of no activity or bed rest or whatever is reduced. Disadvantages is there's a risk for pin site infection, which could lead to bone infection or osteomyelitis. Non-compliance with cleaning the pins and with activity restrictions, that kind of thing. And sometimes, often this is an overwhelming appearance for the patient. So, if your patient has an external fixator, it's important to teach them pin care. And pin care, you need to follow the institutional protocol of where you're working at. There's still more research needed concerning pin care as far as how often it should be done and some of the specifics of it. But in general, I want to teach you that usually it's done 1 to 2 times a day, and then maybe done less frequently after an initial period of time. The general principle that you should utilize is 1 sterile cotton swab per pin, and you want to clean from clean to dirty, starting at the pin site and moving in a circular motion out. Usually a chlorhexidine solution is used. You should be assessing for drainage, redness, loosening of pins, or any tenning of the skin at the site, which is skin rising up at the pin. The provider should be notified of all these assessments. Teach the patient how to clean around the pins. Teach them to watch for signs and symptoms of infection. If activity is restricted with an external fixator, teach deep breathing and leg exercises to prevent deep vein thrombosis, or DVT. Teach activity orders and information on covering the device, etc. Remember, the external fixator should never be pulled on or used to move the extremity. Nursing management. So this is nursing management for all fractures, but it also applies to the care of a patient who undergoes surgery and gets an ORIF, open reduction internal fixation. Important teaching related to the treatment regimen. So if they're going to surgery, you will be doing preoperative teaching, which includes nothing to eat or drink for a specified period of time, usually after midnight, and them signing the consent saying that they understand the procedure, and teaching about avoiding postoperative complications. You also will be involved in teaching the specific treatment modality that's picked and what kind of self-care is involved, any restrictions. Teaching medications, especially regarding pain management, explaining to the patient potential complications that can arise and how to prevent them, and the activity ordered by the provider, any physical limitations that the patient has. Pain relief is high priority. Patient may be prescribed ice, elevation, usually should be at the level of the heart, and narcotics. Unrelenting pain could represent complications. So unrelenting pain, we need to think about compartment syndrome or a possible pressure ulcer. Improving mobility is important. Every joint and digit that's not immobilized should be exercised and do range of motion. Move digits and joints distal to the injury hourly while awake to prevent complications. So patient can do flexion, extension of the foot, calf pumping exercises. They may use the trapeze bar to exercise, and all this helps to avoid skin breakdown as well. Need to maintain neurovascular function. Remember I talked about the 5 P's. What are they again? So pain, poikilothermia, which is cold limb, pallor, paleness, paresthesia, which is numbness, pins and needles, tingling, and pulselessness, which includes weak pulses or delayed capillary refill. Surgeon needs to be notified immediately if these are present. So normal findings that we hope to find on a fractured limb would include minimal edema and discomfort, pink color, warm to touch, capillary refill within the normal range, normal sensations, and ability to move their fingers or toes. Continued nursing management on the next slide. We need to monitor for pulmonary complications, which are most commonly atelectasis and pneumonia. These are especially a threat to our elderly patients undergoing hip surgery. Prevention of pulmonary complications includes deep breathing exercises, change in position every 2 hours, use of incentive spirometer every hour while awake. Assess breath sounds at least every 4 hours and check oxygen saturation. Watch for any symptoms of heart failure, which is a frequent cause of mortality in patients with fractures. Left-sided heart failure involves shortness of breath, cough, shortness of breath on exertion, and crackles in the lungs. Right-sided heart failure involves peripheral edema, jugular vein distension, and abdominal distension. Call the surgeon for signs and symptoms of excess fluid, and often diuretics and fluid restrictions will be ordered. Monitor for signs and symptoms of skin breakdown. Proper skin care, turning, and frequent repositioning every 2 hours are necessary to avoid skin breakdown, and sometimes a special mattress might be ordered. Infection. Report persistent moderate pain, chills, fatigue, elevated white blood cell, and elevated SID rate. These could all be signs and symptoms of infection. Assess the surgical site for redness, warmth, tenderness, purulent drainage. An important marker in the elderly is the decline in the patient's functional status and/or the presence of confusion. And if this occurs, you need to assess them and consider if infection could be a contributing factor. Also monitor for urinary retention. Monitor intake and output, voiding patterns, and note any bladder distension. Patients should notify the nurse of bladder fullness or if they have the inability to void. And constipation. Constipation can be a problem with inactivity and pain medications. Need to be keeping accurate intake and output, assess bowel sounds, noting any distension and decrease in bowel sounds. Need to promote high fiber in their diet and fluids. Activity as allowed by the provider. Stool softener, laxatives, and enemas can also be helpful. So early fracture complications. Early fracture complications include shock, fat embolism, compartment syndrome, thromboembolism, and DIC. Signs and symptoms of shock include increased heart rate, weak, thready pulse, decreased blood pressure, rapid respiratory rate, cool, clammy skin, delayed capillary refill, anxiety, and sometimes thirst. Fat embolism, compartment syndrome, and thromboembolism I'm going to discuss in more detail. And DIC we will not be discussing in detail, but just so you know what it is, it's a severe bleeding disorder in which simultaneous bleeding and clotting occur. The patient is mostly moved to intensive care unit. So fat embolism syndrome, let's start with that one. With fat embolism syndrome, fat globules are released from the bone marrow into the circulation. And why does this happen? Well, the marrow pressure is greater than the capillary pressure, or catecholamines, which are increased with stress, mobilize fatty acids. The problem with this is that the fat globules may occlude small vessels that supply the lungs, brain, kidneys, and other organs. Risk for fat embolism syndrome include individuals with fractures of the long bone or pelvis and hip fractures. Also, those with multiple fractures, trauma, or crushing injuries are at risk. It is more common in 20 to 30-year-olds and elderly with hip fractures. Signs and symptoms. Presenting features, change in behavior and disorientation. This is one of the earliest signs due to low oxygen level. In addition to the change in behavior and disorientation, there will be respiratory compromise. Usually fat embolism syndrome is rapid onset, usually 24 to 72 hours after the fracture occurs. Respiratory issues include hypoxia, difficulty breathing, shortness of breath, rapid respiratory rate, crackles, and you might see acute respiratory distress syndrome on a chest x-ray, which would be a complete whiteout. Cardiac signs and symptoms include fast heart rate and chest pain. Systemic effects include a fever, usually over 103, and petechiae, which I'll have a picture to show you in class about that. Petechiae can be in the mouth, upper neck, chest, and anterior axillary folds. Patient may also appear pale. How do you differentiate between a fat emboli and a blood clot or pulmonary embolism? Well, the distinguishing factor is petechiae with the fat embolism. Prevention and treatment. Prevention includes immediate immobilization of fractures, including early surgical fixation. Adequate support during turning and positioning, maintaining electrolyte and fluid balance are all things that can reduce the incidence of fat emboli. The nurse should monitor closely high-risk patients and maintain bed rest. Prompt respiratory support is necessary. Often steroids are used to treat inflammation, and patients are treated with high oxygen amongst other treatments. Okay, moving on to compartment syndrome. Compartment syndrome is increased pressure within a limited space, such as a cast or a muscle compartment, which results in compression of the blood vessels and nerves, which leads to circulation and nerve compromise. There are 3 types of compartment syndromes. Acute involves a sudden and severe decrease in blood flow to the tissues, and this is the type I will be discussing. Chronic is associated with lots of stress and exercise, and crush compartment syndrome is caused by massive external compression. Example of this would be a car falling on a mechanic. This kind of compartment syndrome, crush compartment syndrome, can lead to kidney failure and possible organ failure. Permanent damage develops within a few hours if action is not taken. Common sites for compartment syndrome include the forearm and leg muscles. Risk factors include trauma from accidents, surgery, or crushing injuries, or casts or tight bandages that are too tight. Moving to the next slide, assessment and signs and symptoms. Clinical manifestations: paleness of the limb, cool skin temperature, delayed capillary refill, weak pulsations, paresthesia, which is numbness, tingling, burning, and decreased sensation. It's important to remember that paresthesia or numbness, burning, and tingling are early signs of compartment syndrome. So unrelenting pain that is not relieved by position changes, ice, or pain medicine, or pain that is disproportionate to the injury, or intense pain when passively moved, could be signs of compartment syndrome. Late signs of compartment syndrome are pulselessness, and also the presence of a pulse does not rule out compartment syndrome, but pulselessness is a late sign. Treatment for compartment syndrome. Notify the provider immediately. He will work to release restrictive devices, or perhaps a surgical incision called a fasciotomy may be needed. With a fasciotomy, incision is made through the subcutaneous tissue and the fascia of the affected compartment to relieve the pressure and restore circulation. If a restrictive device needs to be released, the nurse assists the surgeon by maintaining limb alignment and keeping the limb elevated while the surgeon loosens, removes, and cuts the cast in half. So fasciotomy again, if the pressure is not relieved by removing the bandage or cast, or if circulation is not restored, then a fasciotomy may be considered. Intracompartmental monitoring says that fasciotomy should be considered if the pressure is greater than 30 millimeters of mercury. If a fasciotomy is performed, the wound is not sutured, it's covered with a sterile dressing. When the swelling subsides, then surgically repaired or graft tissue is used. Mobility is as ordered by the surgeon, and elevation and assessment are important. Okay, moving on to venous thromboemboli. You learned about DVT hopefully in Nursing 144. So the symptoms of DVT could be swelling in the leg, pain, could be warmth in the affected area, or changes in skin color. DVT and PE are associated with bed rest and reduced skeletal muscle contractions. Those at high risk for DVT and PE are fractures of the lower extremity and pelvis. DVT or PE may cause death days to weeks after the injury. Nurses need to encourage early ambulation, the use of supportive stockings, TED stockings, and sequential compression devices, encourage fluids, and range of motion. The next slide, signs and symptoms of PE. Depend on the size and the location of the emboli, but symptoms may include sudden onset of shortness of breath, restlessness, increased respiratory rate, tachycardia, chest pain, and fever. Sometimes with massive emboli, there could be shock and loss of consciousness. The chest pleuritic pain usually increases with respiration. And the patients often have a moderate amount of hypoxemia. Their oxygen level drops. So how do you differentiate between a fat emboli and a blood clot? They're very similar. The symptoms are very similar. Well, the distinguishing factor for fat emboli is the petechiae in the upper neck and chest that occurs with fat emboli. Again, the prevention of pulmonary embolism, TEDs, pneumatic compression devices, exercise, range of motion, and often preventative anticoagulants are used, blood thinners. Okay, moving on to the next slide, other fracture complications. These other fracture complications usually occur later, if they occur at all. Osteomyelitis is an infection of the bone. Symptoms include constant bone pain, worse with movement, redness and warmth at the site. They may or may not have a fever, elevated white blood cell, and sed rate. Osteomyelitis is diagnosed through a bone scan, cultures at the site, and blood cultures. Treatment includes a long course, 3 months or more, maybe perhaps, of IV and oral antibiotics. Surgical debridement may be necessary to clean out the area. Okay, delayed union is prolonged healing for a union of a fracture, but it does eventually heal. Keep in mind that causes of delayed union include inadequate blood supply, infection, incorrect immobilization of the fracture. Another risk factor is if the patients are on steroids or non-steroidals. Malunion is a flawed union of the fractured bone. This could occur if inadequate reduction of the fracture occurs or misalignment of the fracture at the time misalignment of the fracture at the time, or immobilization. And non-union is the failure of the ends of the fractured bone to unite in normal alignment. And non-union can be associated with infection, inadequate circulation, malignancy, and non-compliance with the activity restrictions. So if there's non-union, treatment is internal fixation or bone graft, or possibly electrical bone stimulation. Cigarette smoking and poor nutrition place a patient at higher risk for delayed healing or non-union. I want to briefly mention AVN, avascular necrosis. The bone loses its blood supply and dies. This is common with fractures involving the femoral head, neck, and it's diagnosed by X-ray. Treatment includes bone grafts, or the patient might end up with a prosthetic replacement, which we're going to talk about in class. And lastly, complex regional pain syndrome, painful sympathetic nervous system problem, common in the upper extremity after trauma, and it's more common with women. Signs and symptoms include severe burning pain, swelling, limited range of motion, and skin changes, and perhaps muscle atrophy. The best treatment is prevention with vitamin C and early active mobilization and elevation. What's important to remember with complex regional pain syndrome is you should not use the affected extremity for blood pressure or blood draws. Okay, on to the next slide, health promotion and disease prevention for fractures. You need to teach patients to take in the recommended amount of calcium, vitamin D, and/or exposure to sunlight. Foods that are rich in vitamin D include most fish, egg yolks, fortified milk, and cereal. Foods rich in calcium are milk products, green vegetables, fortified orange juice and cereals, red and white beans, and figs. Monitor for the development of osteoporosis, especially in women after menopause and those who have a thyroid disorder. Encourage patients to participate in screening for osteoporosis. Engage in weight-bearing exercises on a regular basis and prevention of injuries, such as wearing seatbelts, using helmets, preventing falls and accidents. Use caution. Prevention of injuries is especially important in the pediatric population for the prevention of fractures. All right, we will pick up in class starting with discussing hip fractures. Thank you.